At week 48, please.
Thank you very much. And so on behalf of the entire study team, it's my pleasure to present to you today the 48-week results from the INSPIRING study, a clinical trial assessing the safety and efficacy of Dolutégravir-based antiretroviral therapy among patients with TB and HIV co-infection. By way of introduction, Dolutégravir is now recommended by the World Health Organization as a preferred first or second line treatment for HIV infection. And several countries with high HIV prevalence are rolling out Dolutégravir increasingly, and we're more commonly seeing Dolutégravir in settings where TB is highly endemic. The treatment options for patients with TB and HIV are relatively limited, largely owing to drug interactions with rifampin, which is an essential part of TB treatment. So we need better treatment options and more treatment options for HIV and TB co-infected patients. We know from one previous study in healthy individuals without HIV and without TB that giving Dolutégravir twice daily at 50 milligrams together with rifampin gives similar drug concentrations to giving Dolutégravir 50 milligrams by itself. The INSPIRING study was designed to evaluate the safety and efficacy of Dolutégravir-based HIV treatment in patients with TB-HIV co-infection. And today we'll be showing the 48-week results. So this is the trial design. This was a phase 3B randomized, multi-center, open-label, non-comparative, active-controlled parallel group studies. Individuals who were HIV treatment naive with newly diagnosed tuberculosis that was drug susceptible could be randomized. They were randomized 3-2 to Dolutégravir, dosed at 50 milligrams twice a day during TB treatment and for 2 weeks subsequent to finishing TB treatment, and then 50 milligrams per day after that. Those individuals randomized to efavirenz received standard dose of efavirenz at 600 milligrams daily. Patients were followed for 52 weeks and then were eligible to enroll in an open label extension to receive study medications beyond that period. Randomization was stratified by HIV viral load greater than or less than 100,000 copies, as well as CD4 count less than or greater than 100 cells per millimeter squared, cubed. The primary endpoint was the proportion of Dolutégravir treated participants with plasma HIV viral load less than 50 copies per milliliter at week 48 using the modified FDA snapshot algorithm in the attention to treat exposed population. The modified snapshot algorithm allows for one change of the NRTI backbone related to tolerability. We also looked at other outcomes, including virologic suppression in the efavirenz group, as well as change in CD4 count over time, safety, in particular focus on immune reconstitution inflammatory syndrome or IRIS episodes, as well as emergence of resistance. So here you see the global enrollment. The total sample size was 113 individuals who were recruited from 37 sites in 7 countries. You'll see that the majority of patients were enrolled in South Africa. The first patient in was randomized on January 23rd, 2015, and it took about 2 years to fully enroll this trial. Here are the baseline characteristics and demographics of the study population. On average, people were young with an average age of 33. A majority were men. And you'll see that over half the participants in each arm had a baseline viral load greater than 100,000 copies per mil. 20 to 30% had a CD4 count less than 100 at initiation of treatment. The average time from starting TB treatment to initiation of antiretrovirals was about 30 days, and the most common NRTI backbone included tenofovir, TDF tenofovir. Here are the modified FDA snapshot outcomes at week 48. And I'll draw your attention to the Dolutégravir arm, where 75% of participants met the FDA snapshot outcome of virologic success at 48 weeks. You'll note that 17 participants were virologic non-responders. This was largely due to non-treatment related events. For the most part, these were lost to follow-up. Of those 17, 13 had virologic suppression prior at some point during the study. There were no deaths in the arms. There were no changes in ART, and and there were no changes to ART. There were no adverse events leading to treatment discontinuation. The patients in the efavirenz arm did very well as well, with 82% meeting FDA snapshot outcomes at week 48. So there were 3 participants in the trial that had confirmed virologic withdrawal criteria, and that was defined as having a viral load greater than 400 copies per mil anytime after week 24 on the study. And that was confirmed with a retest 2 to 4 weeks after the initial test. This participant in the Dolutégravir arm started with a viral load of 1.9 million copies, and by the time of the 24-week visit had a viral load of 767 copies per mil, which on retest had not fallen below 400, so was classified as a confirmed virologic withdrawal. There was no treatment-emergent NRTI and NRTI or integrase resistance observed. A second participant in the Dolutégravir arm who met confirmed virologic withdrawal criteria had several episodes of virologic suppression during their time on study, but then subsequently had a viral load of 2484 at the 36-week visit, which when rechecked was still above 400, so met the criteria. There was no NRTI treatment-emergent resistance, and the integrase genotype failed to amplify. One individual in the efavirenz arm also had confirmed virologic withdrawal after initial virologic suppression, had a high viral load of 76,000 at the week 36 visit, and resistance testing showed emergence of NRTI and NNRTI resistance. So this is just to show you the virologic response over time. I'll draw your attention to the blue line, which is the Dolutégravir arm. You can see that by 4 weeks of treatment, over 50% of participants had a suppressed viral load. That's not surprising. If you look at the pharmacokinetic data in the table on the far right, you'll see that drug exposures when Dolutégravir was given with rifampin and dosed at 50 milligrams twice a day were very similar to Dolutégravir dosed at 50 milligrams a day following completion of TB treatments. The median change in CD4 count in both groups was approximately 200 over the course of the 48 weeks. TB treatment outcomes in both groups were excellent, with treatment success of 88% in the Dolutégravir arm and 91% in the efavirenz arm. So regarding safety, I'll draw your attention first to drug-related SAEs. There was 1 in each group. These were TB-associated iris events. Neither necessitated treatment discontinuation. There were 2 adverse events leading to withdrawal. Both were in the efavirenz arm. One was related to efavirenz hypersensitivity, and the other was a grade 4 elevation in GGT. Psychiatric adverse events were also assessed over the course of the study and were 7% in the Dolutégravir arm and 14% in the efavirenz arm. Regarding iris events, there was an independent adjudication committee that was masked to treatment assignment that looked at all potential iris events. There were 4 TB-associated iris events in the Dolutégravir arm and 4 in the efavirenz arm. None of these resulted in treatment discontinuation. There were 2 non-TB-associated iris events in the Dolutégravir arm, 1 strongyloidiasis and 1 herpes zoster. Again, neither of these resulted or necessitated treatment discontinuation. Similarly, there was 1 patient in each arm that had a grade 3 liver chemistry elevation, particularly ALT, between 5 and 10 times the upper limit of normal, and neither of these met stopping criteria for drug-induced liver injury. So in conclusion, Dolutégravir 50 milligrams twice a day, given concomitantly with rifampin-based TB therapy, demonstrated high efficacy and good immunologic response through week 8. 75% of participants met the FDA snapshot definition for treatment response at week 48. Among those who were non-responders, largely that was for non-treatment related reasons. For the most part, these were lost to follow-up events that happened really over the full course of the 48 weeks without any specific pattern. Dolutégravir concentrations were at or above targets in the patients in the study. Dolutégravir also was very well tolerated. The majority of the adverse events were grade 1 and grade 2. There were no iris events or liver toxicity events leading to drug discontinuation, and TB treatment success in both groups was high at about 90%. So this study provides evidence. We think that Dolutégravir is effective and well tolerated in patients with HIV and TB co-infection, and that this treatment could be offered to that subgroup of participants and will represent an important treatment option for this particular group. We're really grateful to all of the patients who participated in the study, as well as the extended study team. Some of the investigators are listed here, and thank you for your attention.